PBT contouring لهاي الحالة ممكن أصعب شيء، لأنه طبعا هاي الحالة معمولها radiation سابقا، فبيصفي الوضع مش كتير سهل. هلا أنا بس عشان أسهل عليكم الموضوع حبيت إنه أورجيكم كيس شوي أسهل فيها البي بي تي. لو سمحتوا يا جماعة الصوت بس بعد إذنكم. هلا دائما وأبدا لما تيجي تعرف وين الكراينة you look ideally at the three windows. I don't know, Dr. Weil, do you want to come or? So can we change to the mediastinal window please? So you look at the three windows. الهدف ان انت بدك تتعرف على الكارتلج وبعد هيك تطلع 2 centimeters above that. And the cartilage طبعا هاي الحالة انتم ما يعني هاي حالة يعني ثانية انتم ما عملتوهاش كونتورنج لانه شوي اسهل فيها البي بي تي. فبس لو ممكن انصغر شوي to go in the middle of the PBT exactly. اوكي ممتاز. يعني هلا انت احسن اشي تعمله انه شايف وين بالضبط الكرسر تبعي؟ هو هذا الكرسر هون لو بتشوفوه على الكورونال ايميجز. هلا هذا هو مكان الكراينة، فاحسن اشي انه تحط الكرسر عليه وبعدين تطلع منه 2 سنتي. This is 3 milli cuts, so you need to count around 7 slices. اوكي هلا بعد هيك نحول لللونج ويندو. Do you want to do anything?
No, I just wondered, did you want to see this figure?
Oh, it's okay for now. So actually we can so بس تعمل identification لمكان الكراينة. We can just use one window just to make it a little bit bigger. So هلا احنا دائما لازم نتذكر الاناتومي كتير مهم لما تكون عارفه. هلا احنا هون زي ما حكينا اول اشي بلاقينا right main stem bronchus, right upper lobe bronchus. هلا بيعطيك 3 شغلات، في 2 منهم هيهم هون شايفهم، في واحد فوق هي هون. اوكي لانه طبعا بيطلع هداك apical. ف whenever you see that bifurcation you stop there. So this is right upper lobe bronchus, very easy, very simple. Make sure that you're in the long window to capture the entire thickness of the wall. اوكي هلا بننزل لتحت. We go down. شو بنلاقي هون؟ بنلاقي ال right middle lobe bronchus. Bifurcation is on the same slice. Okay, so relatively easy. It gives you lateral and medial, and you stop exactly at the bifurcation. So هذا هو ال bifurcation. هلا you keep هلا احنا حكينا المشكلة الأساسية بال right lower lobe. هلا ال right lower lobe what you need to see is the superior segment. هاي ال superior segment هون. شايفه قد ايه طالع عالي؟ و that's absolutely normal. بعد هيك you need to see the medial. So this is the medial. اوكي لسه ما وقفنا. انتبه على الكاليبر هون كتير اصغر من فوق. So it doesn't mean anything. Okay, we're still right lower lobe bronchus. So this is the medial. حكينا this is the superior. Okay, it came off quite high up. That's also okay. This is medial. هلا this is now anterior here. ما بعرف إذا شايفينه يا دوبك مبين. We're still contouring, and this is bifurcation. So it seems a little bit strange because you're going down into what seems like a very narrow caliber bronchus, but that's how it is, at least from an anatomical standpoint. بالنسبة لل left side, okay, again, the trick is not to go too much high up. A lot of people would go here. That's incorrect because this is apical posterior segment. Okay, and then your lingular bronchus, it should go down. So again, not super clear here, but this is lingular bronchus in my opinion, and now it has bifurcated. And then left side, similar to right side, you have your superior. So superior has probably come off here, not very obvious, but you can just about tell it. And then medial and anterior, usually they come off at the same level. So medial and anterior, in my opinion. And then that is your bifurcation. And to sense check عشان تتأكد ان انت بتعمله صحيح, where is the level compared to the right side? Are we higher or lower than the right side? We're higher. We always have to be higher than the right side. So if we're higher, you know you've not over contoured. So this is a simpler case. هلا نرجع على الكيس تبعتنا. So okay. So this is our case. We're gonna turn off esophagus for now. Okay, so again, for the interest of time, I'm not going to identify where the carina here, but on this specific data set, it's on slice number 40. So you can check it for yourself, the people who have done the carina. Because there is significant change in anatomy because of previous radiotherapy, it's a little bit more difficult here. So again, right main stem bronchus, I think quite clear. Your upper lobe bronchus is pretty much not that obvious. So it's somewhere here. You cannot really see it. There is a lot of collapse around it. So that's absolutely expected. هذا اللي بتتوقعه. بعدك تنزل بالاناتومي، انت عارف الاناتومي تبعك، لازم تشوف رايت ميدل لوب. هاي الرايت ميدل لوب. اوكي، والبايفركيشن تبعها is very clear. يعني there is nothing clearer than this. lateral and medial. بعدك تضلك ماشي تحت. هلا انتبه على superior segment. Superior segment probably has already come off. So شوف الغرابة هون. Superior segment has come off before your right middle lobe. هاي superior segment. Very clear, and I don't think anybody can dispute this. هايها. Because of the change of anatomy, that's expected. Okay, فأنت superior شفتها. هلا صفى تشوف عندك ال anterior والmedial. هلا anterior probably this is the anterior. هلا medial I don't think you can see it here. Again, expected because of change of anatomy. So your bifurcation is here. So again, this is my personal opinion, and this is a case which was done by a consultant in Glasgow, and I agree with his contours. You can have a little bit of subjectivity here because the anatomy is not that easy. هلا بالنسبة للleft side، اوكي، هلا احنا زي ما حكينا ما تطلع في الابيكوبوستير، احنا ما طلعناش في الابيكوبوستير. Lingular bronchus bifurcated, I think that's also clear. هلا هون في عندك superior. This is the superior. Okay, it has come off. هلا بدك تشوف anterior والmedial. يعني you can tell that something has come off here. The other one probably is not that clear. But I personally think you should not go down lower than this. So هذا اللي احنا عملناه. هلا بدنا نشوف participants شو عملوا. Okay, so we have a difference of 2 slices, which is fine in the upper part of the trachea. I think accepted. Probably 1 slice would be accepted. If you keep on going down, so far ما فيش أي discrepancy. خلينا نركز على الجهة اليمين أول إشي. Okay, هم راحوا ورا. شوف أنتوا يعني رحتوا على superior. So this is superior segment. So this is, I would say, it's not a major issue, but it's not right. Okay. هلا medial, you've missed it. You've missed the medial. هلا you stopped contour a little bit too early, I would say. هلا you've continued, I don't know, you've put another slice here, I don't know by mistake or not. هلا بالنسبة left side, يعني to me this is a little bit too much outward. But then there's not much discrepancy. Yeah, this is too big. So again, you're not just taking there's this rhesus, you're taking it in addition. So this is again wrong, and I don't think you've captured the lower part of it. But for the proximal PBT, you're fine. Does anybody have any questions? دكتور وائل بتحب تورجينا سوري أنا أخذت دورك، ممكن تحب تورجينا البريكل plexus؟ تفضلي. لا، البروكسيمال برونكيال تري حترسموها في حالات التري irradiation، وراح ترسموها في حالات الاس بي ار تي فقط. هي هاي حالة tree irradiation. There is a tolerance dose that the proximal bronchial tree should not exceed. And we can touch briefly upon this at the end. and we only do it for rare edition and SBRT cases. بس دكتور وائل حاليا نحاول نبين كل الفرتبري على الساجيتال. الناس اللي انتوا عملتوا البي بي تي صحيح؟ اوكي، مقتنعين يعني الديسكريبنسيز الموجوده ولا في عندكم اي اراء اخرى؟ هو المهم تطلع على الاناتومي، طالما انت متطلع على الاناتومي ومتطلع على هاي السكيماتيك اللي انا ورجيتكم اياها، احنا بنقدر نبعث لكم السلايدز ان شاء الله. You should be fine. هلا can we just show on number 2 if we go down, يعني if we pan this down a little bit. ايوه اوكي perfect. So هلا البريكال plexus again it's not an easy structure. هلا شو بنعمل احنا هون؟ بنطلع احنا يعني كويس هون ان احنا واصلين لفوق، فبصراحه هاي حاله نسبيا سهله من هذا المنطلق، انه انت واصل لفوق، فانت عندك هاي C2 3 4 5. احنا we should start here. اوكي هلا let's see if we've started correctly or not. So again 2 3 4. So 4 5 is here. So yes, we have started correctly. So this is the author contours. Okay, it's very easy here because we've gone high up. Again, for lung cancer we only care about the caudal, يعني التحت من البريكال plexus، فمش لازم تصور لفوق، بس it makes it easier. السلايدز اللي فيهم exit nerve you contour the exit nerve. هلا بالنسبة للسكالين muscles، شو مبدأ السكالين muscles؟ هلا انت you want to identify muscle structures which originate from the transverse processes او posterior processes of the vertebrae وبيفوتوا في الريبس. فهلا انتوا يعني لو ننسى هذا الكونتور for a while، هلا انت you have two muscle structures here. هلا let's chase them وخلينا نشوف وين راح يجوا معنا. هلا اذا فاتوا في الريب صفوا هم هدول اللي احنا بدنا اياهم. اوكي هلا شوف هاي المسل structure. اوكي this is inner rib. اوكي خلينا نشوف وين تطلع. اوكي this should be anterior scalene. هلا اللي وراها هاي صفت الميدل scalene. اوكي وين بتفوت؟ كمان مرة حتفوت على الريب. just follow it so it disappears here. so هلا انت عرفت انه هدول هم الانتيريور والميدل scalene تبعونك. شو بصفي بدك تعمل بعد هيك؟ انت عرفت وين محل الكونتور، عرفت وين sub inf الكونتور should start between fourth and fifth space. من تحت بدك تطلع على structure اللي هو vein artery nerve. هي vein هي artery. انت لو تسأل الناس if you ask people who've done this scan they will tell you that they've scanned quickly after the contrast injection. So this is the artery and then the nerve is posterior to it. هلا from a lung cancer standpoint what we deal about is typically the caudal most, the posterior most. So as long as you're capturing the contour properly here you're fine. خلينا نشوف شو الauthor contours هون. أول إشي هدول الauthors. So we've captured that posterior bit. كمان مرة بنشوف وين السكند ريب. هاي الفيرست ريب هاي السكند ريب. Okay, so this is the second rib. So we no longer see a structure here. So it's a little bit before that it has crossed the neurovascular bundle, but we've stopped contour because we can no longer see the structure. And we contour posterior. Okay, some people would just take the entire neurovascular bundle, it's fine, but just make sure that you're a little bit generous posterior. يعني مش منطق تاخذ الارتري فقط تيجي تحكي I've captured the brachial plexus لأنه الدوز الأعلى حتكون ورا. Well, this is especially true if you have an SBRT case which is quite cranial within the apex of the lung. So if we keep on going up راح تلاقي كمان مرة إنه صفى هلا الكونتور ما بين هدول التو muscle structures اللي احنا حكينا عليهم الانتيريور والميدل scalene. وبالسلايدز اللي فيهم exit nerve root we're gonna contour that as well. So I think this is a relatively easy case when it comes to brachial plexus. هلا نشوف الكونتورز تاعون. يعني I think have two people contour two groups ولا one group؟ Okay. So start level, we're both agreeing on the start level, which is very good. Okay, so احنا identified. بس الشغلة الوحيدة إنه we've not agreed on إنه is this an exit nerve root or not. I would say not, because شوف تطلع هون انت هون الليفل تبع الاكزit. اوكي بعدك لما تنزل لتحت you're not on the exit nerve root anymore. So you just contour between the muscle. ولكن حقيقة يعني I'm happy with the place of the contour. So يعني لأنه we care about maximum dose or near maximum dose, so you've captured our entire contour, which is great. What do you think, Dr. Wael? Again, so this is a little bit of a tricky area, because this is where you stop seeing the muscle as clear, and you're still not seeing that vein artery nerve. So there's a lot of discrepancy in this level, and I tell you, I personally don't know the solution for this. But it just needs to run like homogeneously from up down. So I would say this is my only advice. And as we go down, so again, I think you're not going down enough, particularly here. So you can clearly see it here. I think these slices, very clear, brachial plexus still present. Okay, so you've contoured a little bit insufficiently caudally. And then here, I don't know what that is. But then here, that is acceptable to some extent. So these contours are acceptable. And I would say within what we'd expect as normal discrepancy. So this is very good. Well done for the people who've done the brachial plexus.
Yeah, just to acknowledge that the group have difficulty with the connection, so
Okay.
they done a great job.
So what was the who were the people doing it? Dr. Suha's group. Okay. So did you benefit from peer review or not really? Okay.
She's the chairman of the department right now, so if she's not getting any benefits, so I should go home.
No, but it's good. You know, so Mika would say, you know, in S2 contouring workshops, we see much more discrepancy than this.
Watching all of us like a vulture, so he's writing a report for me too. Thank you.
Esophagus here is relatively easy. So again, we use mediastinal window for esophagus, or you can use the head and neck window. That's fine. So you start at the cricoid, and pretty much it's obvious that it has started here. So make sure that you capture the entire thickness of the wall. Okay, so this is author contours to start off with. Okay. Sometimes at this level, it starts becoming at the interface of the lung. I sometimes also use the lung window a little bit just to make sure that I'm capturing the entire thickness. But here it's not doing that. It's usually quite difficult to contour here when it's contracted. And sometimes you just need a little bit of interpolation. The contrast helps. So, you know, you can clearly tell where the heart ends and the esophagus starts. And again, the azygous vein. Yeah, so it's quite far away, so you can tell it across quite easily. So yeah, and then we stop at the gastroesophageal junction. What did the participants do? So discrepancy of about 2 slides, acceptable, I would say, and then pretty much good agreement here. I guess this is by mistake. So here usually it's the most difficult, and you know, you just need to imagine that it usually has this triangular shape. So don't underestimate this aspect of it. So the left side. Okay, so just ensure that you're contouring the entire structure. And I think maybe here you're on some of the slides at least you're not doing that. Again, don't mistake vascular structures for esophagus, and just going up and down can tell you that trick. And then maybe no, so yeah, so two slides discrepancy. I don't think it has already started there. but again, that is not going to make much difference. So for esophagus, we usually care about so V34 and mean dose. And we have an upcoming in next Estro. We're going to present some pooled data from around 2,000 patients about esophageal constraints. So does anybody have any questions? Dr. Ming, do you have any comments?
I think everybody did a great job.
Yeah.
I have a question from the clinical point of view.
Yes, please, Dr. Wael.
So with the improvement of in systemic treatment, immunotherapy, and multiple targeted therapies in lung cancer, what do you think the fitness, where you can fit the re-irradiation in with this coming systemic treatment?
Oh, excellent question, Dr. Wael. I would say the short answer, I'm not entirely certain. I think if you have a case which is a local recurrence and full-blown re-irradiation and has driver mutations such EGFR, ALK, TKI positive, I would say this is always option number one over and above re-irradiation. There's no question there. I would say if you don't have any option from an immunotherapy, biological agents, you need to think about re-irradiation surgery. If possible, surgery usually is not possible. If you have a case which is high PD-L1, I think you have some debate there. I would say if you have level 1 evidence, obviously if you have high PD-L1, that trumps everything. So I would probably go with immunotherapy. But again, it depends on the situation. You know, if relatively young patient, isolated site of recurrence locally, fit otherwise, can tolerate re-irradiation, lung functions are good, you can kind of think about re-irradiation. But if the patient does not meet these criteria, I think, you know, single agent immunotherapy or combination chemoradiation, a combination chemo-immuno is the way forward.
And in this context, let me phrase it this way. Would you think, not only for the primary recurrence, primary lesion in the lung, even the metastatic lesions in the lung, if I'm having a single lesion that can be reached with SRS, are you pro SRS or you are against? Because I have seen and I have done myself cases of non-small cell lung cancer, of metastasis to lungs. I did SRS actually, and after 2 years, which is a survival I didn't witness when I was in the age of most of the people in the premises, the patient came again with like a satellite away, and I did again SRS and everything goes well. So I know this is not the case, this is not the first thing in the guideline, but what do you think about irradiation and re-irradiation with SRS rather than the IMRT or VMAT?
I mean, case selection is absolutely vital. So I would say if you select the correct cases, in some cases you would benefit from re-irradiation and SRS to the secondaries. Ideally, like what Dr. Umesh and his team are doing now in Tata, you want to have like a prospective registry where you register your data and you capture that outcome, because ideally you want to compare to systemic treatments alone. I don't think we're ever going to get, you know, high-level data. I suspect not, because obviously a lot of people are already practicing it. But testing the biology is important. So I think if you have a case where you need to irradiate locally and also treat a distant metastatic site, if it's one by SRS, I think you need to probably test the biology using systemic treatments for a couple of cycles first. Make sure that there is no metastasis before you embark on what would potentially be toxic re-irradiation. But again, it's up for discussion. I don't know, Dr. Umesh, Dr. Ming, do you have anything to add?
Relatively how much risk you're taking by doing a re-irradiation versus the benefits. If the patient has no other choice, you want to take that risk because cancer is a bigger risk. But if you have other good options, you could start with that.
Yeah, I think the key is individualization of treatment, and then that comes from MDT. So I think everybody.
What makes research and getting data is far much difficult.
So everybody.
We are individualizing a treatment per patient. So one size fits all for a larger data for many patients to go for a specific line of radiotherapy, I think it would be difficult, as Dr. Sam has said. We are sculpturing our treatment for each and every patient, so the data is so much individualized. I'm backing you up.
As Dr. Ahmed said, that I think it's very important that all of us get together and bring out good data so that we get some hint or clue as to what can be offered to these patients. So I think that is key.
So just, can I have the slides, please, if you don't mind? So just again, briefly, unfortunately, we did not have time because not a lot of people did the homework to look at the second case. So the second case is an SBRT case. So if you have time, you can potentially do the contours and submit them and compare to yourself to the author. The last thing I wanted to say is just quickly, if you can give me slides. So I just wanted to quickly tell you, if you potentially are thinking of implementing reirradiation, these are some things to consider. So these are the things that we apply in my institution. So ideally, you want to have histological confirmation. You don't want to embark on reirradiation unless you have histological confirmation. However, an MDT consensus that this is indeed recurrence is acceptable. You want to have recent diagnostic imaging. Brain MRI, I think, is a must, even if you have early recurrence. Performance status, ECOG maximum 2. I wouldn't reirradiate anybody who has PS3. Interstitial lung disease, in my point of view, is an automatic exclusion. They do very badly with radiotherapy. So we've shown previously that their outcome is much, much worse than even patients who have severe COPD. In my institution, we need to have 6 months at least between the first radiotherapy and the second radiotherapy. We don't have any cutoff for lung functions, and we've actually treated patients who have FEV1, believe it or not, of 7% predicted, at least for the first lot of radiotherapy. I think functionally, how the patient is from a shortness of breath point of view is more important than pure lung functions. And you always discuss with a medical oncologist, like Dr. Wa'el and the surgeon, always discuss this in advance. And don't be territorial. Don't think that it's, you know, my treatment or not. It's the best treatment for the patient. Sometimes TKI, you know, obviously TKI, ALK, EGFR treatments are better, definitely. Less toxic, probably more effective. And if surgery is possible, I think that would be ideal. Like Dr. Ming said, I think individualization and, you know, a risk-based approach where you discuss the risks with the patient is super important. Also, from a medical legal standpoint, you need to document all of these in the consent form. And what we tend to do for reirradiation cases is after we do the plan, we bring the patient again after we know the organ at risk doses, because then we can estimate better the toxicity for each organ. And lastly, you would want to do SBRT if this is technically feasible. So if it meets the SBRT guidelines. So this is not ultracentral tumor, but you need to ideally deliver BED more than 100. If you're not achieving this, I would go with fractionated radiotherapy. We prefer 60 grays in 30 fractions, not 66, so 60 and 30, evidence-based approach, and not hypofractionation when you reirradiate. We always prioritize organ at risk constraints, and now there has been published constraints which are consensus agreements between experts worldwide. You can look at these. I was privileged to be part of these. So we always prioritize this over and above PTV coverage. And that means that we can sometimes drop the dose in the PTV. So heterogeneous dose within the PTV. So some parts of the PTV might get the full dose, other parts might have a reduction in dose because you need to meet these organ at risk constraints. Like what Dr. Ming said, CTV margin can be reduced to 0 if required. And we tend to look at 0.5 Dmax, not absolute Dmax. And we tend to look at PRV just to make sure that we are safe. So for this case, the dose was charted. So 54 grays, thrice, 3 times daily. But yeah, that is an important factor that you need to factor in your discussions about reirradiation. Because sometimes if you have done SBRT before and the organs at risk have maxed out, Sometimes you cannot do it again. There is very good guidance now on spinal cord tolerance doses, and so these are just for your information. So these are the expert survey. So this is consensus agreement among lung radiation oncologists on what maximum doses they accept cumulatively for organs at risk. And this is also what we published from the Christie. So this is what we used to accept when I was working in the Christie. And I think anything between these or these is acceptable. And just for your information, there has been newer publications about spinal cord that take even the dose higher than what is written in this table. Does anybody have any questions? I don't want to go over time, so anybody has any questions?
Let me take the chance to thank the ISTRO, Dr. Salim, Dr. Wael, and definitely the man behind the success, Mikan. We like the guy who is serving actually the e-learning and the actual physical learning in Egypt. I thank you so much, Dr. Sam, for gathering with us for many times right now in the radiotherapy in the BGICC. Thank all of the audience. I want to give a little bit of housekeeping that all of the people who are intending to come with us again with Dr. Umesh later today in the cervical cancer radiotherapy ISTRO Falcon session, I urge you to go downstairs to the glass room. We are having a generous offering of the dummy, the applicators, everything for the brachytherapy from our friends in Electa. So try first the practical part, and then we will gather for the planning and delineation later. We are having like 2 hours from now a lunch break, and before it you have more than enough time to visit the glass room down there, and we will gather again at 2 o'clock to have our advances in radiotherapy session, inshallah, with the presence of my dear mentor, Professor Dr. Amin Said, and other friends. Thank you so much, Dr. Sams. Thank you so much, Dr. Wael, for your continuous support to education in radiotherapy, which is very far important, very far advanced right now. We are from the generation, me and my dearest friend, Dr. Muhammad Abul Futuh. We are the generation who started it with the cobalt machines and drawing the planning manually. And now with those kind of advances and those kind of courses that we are offering our friends of younger generation, we are moving things much forward. Thank you so much. Thank you.
For the gynae, we might have opportunity from Electa. They can bring the mannequin and the applicator during the course. It will help.
But right now, we will have the time to do hands-on. During the session, we will not.
You can
have
assemble
the
the heat from Electa downstairs will help you to assemble the applicators.
how to do it.
And they have a mannequin. You can
as if you are doing it.
you can show you how to do it on the patient.
You are most welcome. Thank you so much. We will wait you at 2 o'clock.